Yeah. It was an excellent presentation by Dr. Harbans Lal sir and also by Dr. Ramesh. There are so many new things which have come up, and sure there will be a good discussion. I have got my 7 tips, but wherever there is a repetition, I'll try to skip that slide or go fast on that. So tip number 1 is, first we should start with topography and tomography. Previously, we used to see only the anterior, axial curvature or sagittal curvature. But now everything is important, because these are the things which will tell us whether there is anything wrong with the cornea, whether the Gulstine ratio is altered, whether the patient is post-refractive surgery or post-C3R, pachymetry is high. It will tell us whether there is a fuchs dystrophy, which can of course play havoc while doing toric IOL. But if you come to the 3 important points about topography, we have to see the regularity of the map. Okay. Second is the power, and third is the axis. Power has to be chosen from the non-topography keratometers, and axis has to be chosen from the topography. So I will come to this later on, but according to Holiday, we have to take the 5 mm circle for choosing the axis. Tip number 2. Now, these are the conditions which can create havoc while doing toric IOL calculations. They can be spoil sports. One is dry eyes, already explained by Dr. Lal sir. Then epithelial basement membrane dystrophy, Sazman nodular degeneration, fuchs dystrophy, and pterygium. And these need to be addressed, or you may have to totally skip doing toric IOL. Then tip number 3 is paying attention to the details. Many times we take the K readings from the machine, but do not look at the readings. Now, if you see over here in this particular patient, I hope you can see the cursor. There are 2 dots which are missing in many of these images. Now, this patient had a cylinder of 1.25 diopters, but he had a lot of dryness. And the dryness was not evident, very greatly evident, except for these 2 drops. And he was treated for dryness for about 15 days. And after that, when we saw those 2 dots reappeared, and the cylinder reduced from 1.25 to 0.25. So we just don't take values. We have to concentrate. We have to look at the map or the images of the LEDs properly. Then the next tip is analysis of the cylinder. So as Dr. Lal has already shown, that many times we get different kind of reading. So what practice I follow is that I take readings from 3 machines, and one of them is of course a topographer or tomographer like a Pentacam or a MS39, plus IOL Master or Lenstar, and plus any machine like Varion or any dedicated keratometer. Now, we divide the patients into 3 categories. Grade 1 is when, I'll just minimize this. Yeah. Grade 1 is when, grade 0 is that there is no match at all. That means the difference in the power of the cylinder is 0.25. Mind you, we are not comparing the K readings, but we are comparing the cylinder. And the difference in the axis is more than 10 degrees. Over here, I'll go back to the manual keratometry. Now, why manual keratometry? That is the only static keratometry which is not largely dependent on the dry eye status. Okay, whereas if you have so much of variation, most likely the patient has an abnormal cornea or dry eyes, and then best is to go to the age-old method of manual keratometry. Then comes grade 1, when the cylinder is more than 0.1 but less than 0.85, and the difference in the axis is less than 10 degrees but more than 5 degrees. Then we go to Barrett median K or Barrett's integrated K. Barrett has developed this excellent tool where you can feed in 3 K readings from the 3 different machines, and it will tell us what K to use. It does not average out. That's why it is called as Barrett median K or integrated K. And it's a fantastic tool. It is available on all the websites, including APSARS. And the third is all the readings and cylinders are matching very well. That means the cylinder power are within 0.1 and axis is within 5 degrees, and then you can use any of them because the variation is going to be very less. It is possible to get grade 2 readings provided the optos are trained or the technicians are trained properly how to take readings. And that is where comes the position of the head. There is a black mark on the vertical bar next to the patient's head, the position of the chin, rotation, fixation, everything. And if we go and taking the reading before the tear film starts breaking up. So suppose a patient has got a TBUT of 5 seconds, we have to take a reading before 5 seconds. How do you do that? You go very close to, very close where you are about to get a reading. Ask the patient to blink and just move your, joystick forward or backward, whatever, so that you get readings. But suppose the patient has got a TBUT of say 10 seconds, then of course you have got a lot of time. So when we are talking about dry eyes, it is more important to understand what is the TBUT rather than Sherman's. Of course, Sherman's is also important, but from the reading point of view, it is very important to understand what is the TBUT. Then we come to the next step, that what are the possible errors in marking. Okay, now these are the different examples where you can get marks, okay, because of the smudging of the ink or the movement of the conjunctiva or the movement of the patient or wrong alignment of slit lamp. So what we do, we mark, but we measure the axis of the mark. Suppose you mark the axis at 90 degrees, it may be at 87 or 92. And therefore you measure the mark. So you draw a narrow slit which is passing through the center of the cornea, the corneal apex, and the point where the mark is crossing the limbus at its midpoint. And that is the axis of the mark, and you measure it. I'll go back to the previous slide. So like this, now if you see this lower diagram with the bigger circle, this is the axis. So the mark may look slightly tilted because the patient moved or whatever, the patient was squeezing his eyes, but the marks are done at exactly 90 degrees. So what we do is measure the axis of the mark. Okay, and I adjust things accordingly. So you know that your mark is at 87, and then while doing axis marking, you use 87 as the reference mark rather than 90. Then we talk about the corneal ectasia. In keratoconus, we always talk of debulking the astigmatism and treat only when the central 3 millimeter of the cornea is regular. So here I have shown that patient has got a big astigmatism, lot of astigmatism, but it is regular. So very good case for toric, whereas this patient on the right hand side has got an eccentric cone, and then whatever calculations you do, you are likely to go for a surprise. And going little further, corneal ectasia, whether it is keratoconus, post 3-3R or post LASIK ectasia, we calculate, grade them according to topography. But there is a new classification available, Retics classification, which takes into account Q value, best corrected visual acuity, cylinder amount, and high order aberrations, etc. And that works very well. And when according to the Retics classification, the patient has got grade 1 or maximum grade 2 cornea, keratoconus or ectasia, that is the time toric IOL is going to work the best. And as you go ahead more and more into the grades, the astigmatism is likely to, the toric IOL is likely to give you more and more surprise. Then the next tip is measured versus estimated PCA. So there is a lot of talk going on about the Barrett TK or the total keratometry. Why? Because mathematical calculations assume that whenever you have WTR anterior, patient will have ATR posterior in increasing amount as the WTR increases. Whereas when you have ATR anterior, the posterior cornea will have fixed amount of ATR, and which is very small, say 0.25, 0.3. But what we have seen is that all the corneas do not follow this rule, and therefore came the method of actually measuring the posterior corneal astigmatism. But And it is said that Barrett TK also improves the result, but most of the surgeons all over the world agree that in virgin cornea, you should not go by Barrett TK, you should go by a mathematical model, that is an estimated K. And that's why, as of both the speakers have said previously, Barrett universal 2 toric calculator works the best. On the contrary, when you have atypical cornea and the anterior posterior ratio or the Gulfstream ratio is altered, that is the time we use measured. Here it is shown that going by Barrett-Truke method, if you go by, instead you go by Barrett-TK method, there is an improvement in results by around 12 to 14%. So there is no confusion as of now. Whenever you have virgin cornea, don't think of Barrett-TK. Just go by normal Barrett universal 2 toric calculator. Thank you very much.